Good afternoon, everybody. It's a pleasure to be here. I'm really looking forward to a series of presentations and the discussion. Of course, the urban environment for the promotion of mental well-being and cognitive function of older people is very dear to the hearts of those people working on healthy cities. We need to look at the impact of the urban environment on mental health as part of what we do in our normal work. The topic is always of interest to the Healthy Cities Network, both in terms of the measures that healthy cities themselves can do, the city authorities, and also through the engagement with civil society. We can consider how our cities respond to the needs of older people. We can consider to what extent the built environment addresses aspects which enable the promotion of mental health and well-being. We can consider some of the safety aspects. What's it like to be an older person who might be afraid of crime or other issues and find it difficult to go outside and so on. We can consider how we might help to address loneliness and social isolation. And we should perhaps consider also the impact of mental health of potentially being a victim of domestic violence. We often overlook the domestic violence as a potential risk for older people. This is true all the time. It's especially true at this time of COVID-19. The greater isolation of vulnerable elderly as they cocoon or isolate. We can see the increased risk of death, both as an increased risk through aging, but also particularly in terms of deaths in long-term care homes, which has been a particular picture across many of the European countries. And what does that do on people in terms of people's mental health? We also need to think what are the longer term impacts of COVID-19 on the mental health of older people. And of course, the risk factors for mental health and loneliness will affect some groups more seriously. There'll be greater vulnerabilities which may follow out along a socioeconomic status line. So we're predominantly interested in what we can learn from MINDMAP and thinking about some of the policy solutions to address mental health and isolation in older people through the work we can do in cities. So with that, I'd say we're looking forward to hearing what you have to offer to us and thinking about what it means for what we can do in the future. And I'll therefore hand across to Franca to do the introductions from here and to chair the meeting.
Okay. Thank you very much, Chris. So good afternoon, everybody. I have the pleasure to chair today, and so I welcome all of you to the webinar on urban health and aging, policy implication of the MINDMAP result. As Chris has already said, we know in Europe is turning increasingly grey in the coming decades, and so that it is crucial acting for an active and healthy aging for two reasons: for reducing the demand of health care and social welfare, and for reduce what Chris was saying, social and health inequalities mainly. In this context, the burden of mental health is impressively increasing, and it is an increase mostly charged to the elderly population. So while cities pose major challenges for older citizens, they also offer unique opportunities for design of policy, clinical and public health intervention that promote mental health and ensure the delivery of health care services for all people. So today, the webinar faces these issues, starting from the contribution of a MINDMAP project that was founded by European Commission Horizon 2020, that includes 13 partners from different university and research centers. MINDMAP project aims to identify the opportunities offered by the urban environment for the promotion of mental well-being and cognitive function of older individuals in Europe. The speakers today, that are very well-known speakers, experts in the field, will give us a glance on healthy urban policies and how to move from evidence to practice with stakeholder engagement. So, as I said, our speakers have all an impressive experience in the field. And what I do now is to introduce shortly all of them. And so I'm glad that you are connected with the video, so you can just raise your hand and say, here I am. And then after the introduction, I ask to all of you to turn off the camera, the video, so that only the speaker and myself will be connected. Before introducing you another practical information, if you agree, I alert you 2 minutes before the end of your time, so that you can regulate yourself in the timetable. So I start with the presentation of our host, Chris Brookes. I have a special thank for him because he was very supportive and impressively efficient in the organizing of this webinar. He's a consultant providing project management support to the Healthy Cities Network. He has 20 years of experience working in public health within the European region and globally, and has had a focus on a broad determinant of health, and in particular on health inequalities, and has worked closely with a range of different networks. So hi, Chris, I think that all the participants know you. And then our second host is Pirous Fateh-Moghadam from the Regions for Health Network. Welcome. Pirous is a medical doctor specialized in hygiene and preventive medicine. He has a second master level in applied epidemiology. At the present, he is the head of the Health Observatory of Autonomous Province of Trento and temporary advisor of the WHO Venice office. So welcome, Pirous.
Good afternoon, everybody. Thank you.
Then we have 3 speakers from the MINDMAP project. Professor Franca Van Lenthe. Please forgive me if I don't pronounce correctly your name, all of you, who is the coordinator of the Horizon 2020 funded project MINDMAP on mental well-being and aging resident in European cities. Frank is the professor of social epidemiology at Erasmus Medical Center in Rotterdam and professor in spatial diversity and inequality in urban health at Utrecht University. His research is on area-based inequality in health, specifically addressing the role of the physical and social environment characteristic for healthy aging and mental well-being. So welcome, Frank. Mauricio Avendano is a professor of public policy and global health and director of the Institute of Gerontology at the Department of Global Health and Social Medicine at King's College London. He is also adjunct professor at Harvard University. He is interested in consequences of social policy for both physical and mental health, especially for older people. And Professor Giuseppe Costa is medical doctor, epidemiology since 1979, full professor of public health at the University of Torino, head of the Regional Health Observatory of the Piedmont region. Main field of research, of his research, are health service evaluation and social determinants of health. He is a co-leader of the new European Joint Action on Health Inequalities, JAI, aiming to promote progress in policy response to health inequalities. So I think that now we can start our program. I have to say you that at the end we have almost half an hour for questions and comments. So you can raise your hand or write if you wanted to speak, or write a comment or a question in the chat. And we will give, I will give you the room in case you have a specific question for one speaker. Otherwise, please wait to the end of all the three presentations. So I think that if Chris doesn't have to add any other technical instruction, please forgive us for we have been always familiar to these webinars, and we all know that some technical problems can occur. So I think that we are patient and comprehensive each other. So we can start. Okay, good. So we start with Frank Van Lenthe and Mauricio Avendano, who shared the presentation on healthy urban policy, new evidence from MINDMAP project. Frank, the floor is yours.
Thank you very much, everybody. I hope you can all hear me and see me. And in the meanwhile, I can see the presentation, which I compiled together with Mauricio Avendano, and which will discuss a number of issues that we have encountered in this MINDMAP project on promoting mental well-being and healthy aging in cities. We talk about this project as we have gathered evidence over the last few years. The presentation is too short to give right to all the evidence that we have collected. We've selected a number of issues that we think may be important, and instead of giving you direct policy recommendations, I think it's important to say that we'd like to discuss a number of issues that have some policy relevance. And that is also because the field we're in is not new to any of you. Age-friendly cities is a concept that you are all very familiar with, the network of age-friendly cities, the Healthy Cities Network, etc. There is lots of work already done in this field, lots of documents, and what we hope in our presentation is that we can just add to this kind of evidence with our study in MINDMAP. And if we think about MINDMAP, then this is about underscoring the evidence that is needed for a healthy city based on a number of elements. Here you can see some of these elements, like transportation or outdoor spaces, respect and social participation, etc. We will talk you through some of our ideas about the physical environment and the social environment and end up with a conclusion about how to proceed. And actually, when we do so, we try to do this in a way that we, and that's not specific for MINDMAP, but nevertheless very much connected to MINDMAP, is that we've tried over the past to move from determinants to kind of policy relevant questions. And we'll give you some examples of how we've tried to do this, but also share with you some of the issues that brings towards formulating policy recommendations. And we've done so in a large consortium. The MINDMAP consortium consists of 12 work packages with a large group number of participants over time who took different roles. I won't go into detail. There are enough on the website information about what MINDMAP exactly is, but it is important, I think, for all of you to know that this is a large effort across Europe and even with participation from the United States and Canada. And it all starts, I think, with what we have made is our conceptual model. And as you can see, this conceptual model, as you're all familiar with, connects the urban environment ultimately to mental well-being. And in our approach, we've encountered that this offers unique opportunities for health promotion and for public health. Because urban environmental characteristics are characteristics that somehow potentially can be changed and somehow are also changed naturally, both when it comes to social and physical characteristics and even to some structural characteristics such as the population density and levels of segregation within cities. And we've actually considered over time and realized over time that these characteristics may affect mental well-being through different variety of approaches, including health behaviors, but also biological factors, stress, and perhaps even modified by genetic factors, and ultimately leading to mental well-being outcomes. And for us, at least for me, this was kind of the first element of policy relevance, in the sense that I think for each of these outcomes and for each of these characteristics, it may be important from a policy perspective to really start and understand what the pathways are. When I started this project, my impression was that some of these factors, such as walkability in neighborhoods, for example, affected walking, and through walking, perhaps mental well-being. We were all inclined with the idea that health behavior played a particularly important role, and it does. But I'd like to emphasize here as well that there's other approaches as well, that the urban environment may actually raise stress, and that stress may be relevant for mental well-being as well. There are other factors that are important. And when we do our policy interventions, I think it's important that we, at the beginning already, try and understand how these pathways go, that we learn together, science and stakeholders, what the elements are that may be at stake here. I won't go into much detail about the approach that we had, but we did a few specific elements. First of all, we try to make use as much as possible from existing data. When we wrote the grant, when we wrote the project, we identified a number of existing aging cohorts. In these aging cohorts, very detailed information is collected about the process of healthy aging and about mental well-being. And the intriguing thing that we always see in research on urban characteristics and health is that they are often done within a single place. And that is something to think about. What does it mean? I think that for no other field than this field counts, that it is relevant to see what the place is where we do. If we study place and health, then we need to understand what the place is. And it's a bit strange, perhaps, to restrict this to a single city or to a single place. In MINDMAP, we try to broaden the scope. And that's important because if you read papers, if you read studies on this, the findings are often interpreted, or the comparisons between studies are often discussed in terms of methodological differences. And this is something that we've tried to overcome in MINDMAP by including all these cohorts, by harmonizing all the kind of data that comes from these studies, and by subsequently bringing them all together. It was a huge approach, and we're only halfway perhaps. The next years may give us opportunities to do much more work on this, but this allows us to compare particular studies between cities and then getting rid of all these methodological differences. And we connected to all this urban data, to all the data collected in the cohorts. So geographers in our department actually spent a lot of time in finding and harmonizing or using data on the urban environment. And the INSPIRE project, for example, is a great effort. And again, here I think an important policy relevant issue, which is the crucial importance of having good data available. What we've learned over the time from this project is how important it is to have comparable data across Europe. And this is certainly an investment worthwhile doing, because over time we expect, of course, that the role of the urban environment may increase. It was mentioned already in terms of a COVID crisis, for example. We're becoming aware of our immediate neighborhood surroundings and the relevance for health and for other outcomes. And having good data is crucial. I think from a policy perspective, we have learned that having a database available that allows us to compare results over cities may be a fruitful way of further improving our understanding how urban characteristics actually are related to health and why they are sometimes very important and why also sometimes we have to conclude that the relevance is perhaps less. Investing in data is a crucially important element of an approach like this. And here you can actually see some of the results from our study. First of all, this is an overview of the prevalence of probable depression, one of those outcomes that we have harmonized over time, just one outcome of mental well-being, of course, but you can see very clearly how these prevalences vary across cities. We can see the Hunt study in Norway, where the prevalence is extremely low as compared to, for example, these studies in the Czech Republic or in Russia, where the prevalence of probable discussion, measured as much as possible in the same way, is so extremely much higher. And it's this particular variation between cities that we thought was really important for a project like MINDMAP. We can either study the importance of urban characteristics within cities and then realize that, for example, in Russia, 25% of the sample deals with probable discussion, which is completely different than doing this in Hunt. So from a policy perspective, it may be relevant to see whether urban characteristics are related to this kind of variation in the prevalence of depression. Well, as you can see, it is not surprising perhaps that in a rich and welfare country like Norway, in the Oslo region, the prevalence of depression is low. In other words, there are urban characteristics that may play a role, but we should not rule out the larger macro-social determinants as well, the country characteristics that play and shape these kind of prevalences as well. And from a policy perspective, that again means we need to understand exactly what the role of these characteristics is, also to estimate what the impact can be of any kind of policy that we would want to implement. So one element of policy relevance, I think, here is that a comparative approach and collaboration is really interesting. It avoids the situation that we can just cannot interpret our findings as compared to other cities simply because there are so many methodological differences. Urban data are very important in this sense as well, and we believe that it can help to a kind of context-driven understanding. In MINDMAP, we've had lots of discussions about whether we should pool all our data together or whether we should look at this specifically. And over time, I think it has been much more important to understand that cities in Europe differ tremendously and that the role of the urban context is not a single solution for every city. And that perhaps is most clear when it comes to one of the most investigated topics in this area, green space and mental health. There is an abundance of evidence showing a relationship between green space and mental well-being or other outcomes, physical activity, etc. Plenty reviews, and we're all actually convinced of the role of green space for good health. There are a number of problems when we go into what the recommendation should be. One issue that always comes on top is to what extent are these kind of relationships causal? To what extent is it the case that green leads to better health? And to what extent can we exclude that people with better health move into green spaces? We thought that from a policy perspective, it would be interesting to see what would happen if green space changes over time. If, for example, and whether that results to a change in mental well-being. So in one of the cohorts over time, in the Netherlands in this case, we've actually looked at these changes. We have these longitudinal data in these cohort studies, and we've mapped this to longitudinal changes in green space. And this yielded really interesting and important information. We know these associations, we know, and many of us are convinced about the potential role, the important role of green. But as you can see here from this slide, over time, where we actually thought to investigate whether an increase in green would lead to an increase in mental well-being, we actually witnessed that over time, on average, the amount of green in the city of Eindhoven decreased over time. So just imagine the policy relevance of this, that even in the crisis that as we are today in, and where we know that our direct living environment is so important for health, you can actually witness a decrease in green space. We actually think that it is really important to consider this, and given the importance, the evidence that we have already, to emphasize that it should be the other way around. We should invest in green instead of accepting that there is less green. But the problem here was when we investigated whether changes in green were related to changes in mental well-being, we hardly found any evidence. That is not to say that there is no relationship between green and mental well-being, but it is important that the kind of changes that over time occurred in this city were not sufficient to make a change in mental well-being. And from a policy perspective, we could actually say, to some extent, if we want to do anything good for mental well-being, then we need to do it substantially. This is not just a single short intervention. And with substantial, I do not mean that we have in every city a big park or a new park or whatsoever, but at a substantial level across the city, it seems needed to change the environment to make it more green in a way that it can actually at the population level affect mental well-being. But what we've also learned is that our approach of studying this by simply looking at whether more or less affects health is perhaps also not sufficient. We're all aware that not only the amount of green, but also the quality of green, for example, is really important. And it is also important to understand how green in this area plays a role, what the actually use of green is in cities that may be relevant. And here again, I think we need in the future to take a different approach. That's also reflected when we, yeah.
Frank, let me know that you are a little bit short of time. Altogether, you have still 10 minutes, more or less, okay, with Mauricio, okay?
Okay. So here we see a situation with residential density. Again, we see a huge difference between cities. And again, we can see this is important if we consider how urban characteristics play a role. In terms of policy relevance, it means that green and density play different roles. More green perhaps is not always connected with less green. So in the end, we would like to make a plea for bringing this all together in one kind of policy perspective. So let me hand over to Mauricio, who will talk a little bit more about social participation.
Okay, thank you very much, Frank, for this presentation. And thank you again, Franca and Chris, for the invitation to present. So I would like to just take a few more minutes to expand what Frank was saying to illustrate a component of the project that is specifically focused on trying to understand the impact of policies on the mental health of all the people living in cities. One of the things that we did within the MINDMAP project was to create a database of urban and social policies that are important for well-being and mental health in the city, and to link this data to data on individuals from the cohorts that we were studying. And what I'm going to try to do here is just to make sort of a general statement and show you two small examples of what we found. But one of the main findings that emerged from this study is that policies that promote social participation, and be it through a physical intervention or through a social intervention, they seem to offer great promise in improving mental well-being in older age. And this seems to be as a sort of something that is known to us, but we were really sort of impressed with the evidence that interventions that focuses on the social participation through different means might have important impacts. Frank, if you could go to the next slide, please.
Yes, sure.
Thank you.
Yeah.
Yeah, so basically what we did in the project is to try to explore how different policy domains, from employment and participation to transport and housing, for example, have a link to mental health, and try to exploit changes in these policies to understand their impact on the mental health of older people. Next, please. So what I would like to do here is to show you two examples of what we found. One of the main sort of critical claims that have been made, for example, by the WHO Healthy Cities project is this idea that the public infrastructure of public transfer infrastructure is important to mental health. So we started a specific policy in the UK that introduced what is called these free bus pass, concessionary bus passes, and tried to establish to what extent these bus passes, which is basically a free pass when people reach the age of 60 or 65, to what extent they may have an impact on mental health. Next slide, please. Another example of an area that we were interested about is the area of home care. So the system of long-term care that is provided very often by the city council or the city government to all the people. And we wanted to understand how the different structure of the home care system may be important, not only for physical functioning, but also for the mental health of all the people. So we did a study in which we compared different cities across Europe and examined to what extent different eligibility to different home care programs have an impact on depressive symptoms. Next, please. So let me just show you very briefly what we find for the example of transportation. This graph is just a general representation that tries to show you the general finding that those who actually use public transportation more often, older people in England who use more public transportation, they tend to have lower levels of depression. And so when we try to evaluate to what extent this may be due to the policy, next slide, please, Frank. What we find is actually that increased transportation use, which is made possible by having access to a free bus pass, actually reduces depression scores. So it reduces the probability to have depression, but it also actually improves cognitive function. Now, this is probably something that we all sort of can relate to, but what this sort of project does is to actually provide some empirical evidence that investing in public transportation in the form of subsidizing public transportation for all the people has actually enormous consequences for their mental well-being, but also for maintaining cognitive function. Next slide, please, Frank. Coming to the second example of home care, what we did is to evaluate the eligibility criteria for receiving care at home from the government, so subsidized care home from the government, not from informal carers. And we examined to what extent this influences the ability of individuals to fulfill their needs. First of all, what we find is that in places where people have more access to home care, according to what the law stipulates, individuals are more likely to be eligible to receive home care. So this is what you see in this graph. And what we show in this paper is essentially that higher accessibility to home care, to receiving care at home, is actually associated with a higher maintenance of mental health function, particularly with reduced rates of depression. We didn't find strong effects on cognitive outcomes, but we found that home care can be a strong policy tool that can be used not only to help older people to maintain function, but also to maintain a mental well-being. Next slide, please. Now, just coming to a final example, these two examples that I just showed you on public transportation and long-term care are two very distinct examples, and we wanted to look at the impact that a more packaged approach, an approach that will have a set of interventions that intervene on the social environment and the physical environment and other aspects, and how this would impact mental health. So we studied the case of Turin, which during the period from 1985 to 2013 ran a very extensive and complex program of urban regeneration. And we used data from the Turin longitudinal study to try to understand, together with colleagues in Turin, including Giuseppe, to try to understand what the impact of urban regeneration would be on mental health. Next slide, please. And what we find in this study, this is just a summary, is that those who were exposed to areas within the Turin, in Turin and who were exposed to urban regeneration programs tended to have more favorable mental health outcomes, at least as measured by the rest of antidepressant use. reported in the registry data. Now, one of the components that was interesting in this study is that we found that it is really social interventions within the urban regeneration program that were most important actually for the mental health of all people. And these social interventions are sort of people-oriented interventions on social and economic issues, social cohesion, community centers, educational and cultural activities for residents. These interventions together as a package were the most strongly predictive of improvements in mental health among all the people. So this final example is just to say that even though independent interventions such as the bus pass or long-term care on their own can have an important mental health impact, also a package of interventions that intervenes across several dimensions also has the potential to improve mental health, but that is particularly the case where they take into account the improvements in the social environment and the opportunities for all the people to be socially active and participative. So I will just hand over back to Frank, who will conclude.
Yes, I will give a few final remarks to this. We started with our kind of traditional research where we investigated single determinants. I have shown you some examples where we had sometimes difficulties in finding clear relationship, for which there are good reasons, but also it gives us some problems when it comes to policy recommendations. And importantly, also from the types of studies that I presented, and later on also from the work that Mauricio presented, over time we've become even more aware of the fact that so many of these characteristics really relate to each other. And that I think that also from a policy perspective, it is really important that we increasingly adopt a kind of a systems approach. So in one of the work packages that we haven't discussed too much today, we've actually started developing this kind of systems models. And I think these are really a way of going forward for several reasons. First of all, because they actually connect all these kind of urban environmental characteristics and much better are able to describe how all these factors work together towards the same outcome. But importantly also, because it's a structure that really is something that we increasingly need to do, and I'm really aware of that, which is working together with stakeholders right from the beginning to get these kind of models really set up, to understand what I also said, how these interventions might work, what actually could be the intended, but also the unintended consequences of some of these actions. They're really important, and translating this into models really helps us also, because we can play with these models, we can actually investigate what approaches are. So for example, to daily transport, we can actually show how important transport is, but there are so many ways in making a policy that relates to transport. And these models actually help us a lot and are a way of moving forward for both scientists and policymakers. So to conclude, I think although we have had only time of the work that we've done over time in the past 4 years, I think there are a number of threats to the social environment, particularly in this COVID period. Perhaps, and we haven't tackled that very much, residential segregation perhaps in the very first place, a real threat to mental well-being of urban residents, as increasingly we get separated socioeconomically, with huge consequences for our urban environment. But also, as I showed, less green and perhaps less social cohesion. So there is a huge opportunity for urban policies to actually deal with it. And in the COVID crisis actually provides us an opportunity to once again emphasize how important a healthy urban environment is, and that we can actually have entry points both via the physical but also the social environment. Mauricio showed good examples of the social environments. Underlying physical structures may really advance participation and improve the social environment. And as I mentioned, I think a systems approach really answers or can help us in the near future to answer real policy relevant questions. And Franca, I think that's what we tried to say in 20 minutes.
Thank you. Actually, I decided to give you more time than 20 minutes, both because you were two speakers, and I think that it was really a pity to interrupt you. And just a practical information, somebody asked about the presentation, if we can share the presentation with the participant. I think that yes, we can, if you agree, Frank, Mauricio, and Giuseppe.
Yes.
Okay. And now, just if there is somebody who have urgent, specific question related to this presentation, please, you can intervene now. Otherwise, it's better to wait for the discussion time. I think that what Frank and Mauricio provided us is very well connected to Professor Costa's presentation. So we move from the epidemiological and data collection and how can this impact in policy. And so, Professor Costa, the floor is yours.
Thank you, Franca. Thank you, Frank and Mauricio. I think that the conclusion of Frank and Mauricio are all also for this second part of the project, because a small part of the project was dedicated to sorry?
Good. Okay. Now we have the slide.
The small part of the project was dedicated to see how this evidence provided by MINDMAP was able to intercept the stakeholders and decision makers. This was the main objective of this part, and in fact we had 7 MINDMAP cities that have been involved in this activity of stakeholder engagement, and two of them provided 2 case studies, so some more in-depth investment in trying to understand how evidence can reach stakeholders, and 5 more cities provided some smaller experience of local dissemination. In each of these cities, we try to build a stakeholder platform at the city level. And the first conclusion of our experience is that it can be done. Yes, matching evidence with the stakeholder engagement can be done. In Italy, we have done it in Torino with a case study focusing specifically on health equity, on using the health equity measure as the new metric for communicating between stakeholders and experts. In Trieste, we focused on social capital, on what Mauricio was explaining as one of the main subject issue of change and innovation for providing better mental health. And we will have also more from the other cities. Let's start from Torino. The Torino case study is the more complex one, because it started from with the 3 steps prospective initiative. First step was at city level. We involved 50 representatives of the city that working groups in 3 specific workshops. They try to co-investigate the reasons, the evidence, and the reasons, the mechanism of health inequalities, in order to find out solutions to reduce them and to identify responsibilities. And then to ask a higher level officer representative at the city level to initiate a decision process, co-decision for target setting and priority setting. And then moving toward a specific solution and action, implementation action on a specific priority. This was done at the neighborhood level, where 2 communities of practice have been convened for an experience of co-creation, where local action to reduce inequalities in a specific epidemic of diabetes and and city action to enable local action to happen have been implemented. And let's just run through these 3 steps to see why I'm saying that it can be done, and the experience of matching evidence with stakeholders and decision-maker engagement is important and interesting. In Torino, in the first step, it was the co-investigation step. We started from a Turin review, presenting the usual storytelling of how, from the richer neighborhood, the poorer neighborhood, the metro line storytelling, explain how health in this case is life expectancy is decreasing according to the decreasing income. And then we use this data for 3 workshops, 3 very short workshops with these 50 people at the city level, moving from facts to explanation and to solution, and mostly with this kind of interactive work. And from this theory, we move to action because all these people started from health inequalities, identified 23 actions at the city level that were under their responsibility that could reduce these health inequalities. They presented these results to the main authorities of the city, and this authority decided to take the responsibility to drive and bring the change. And the new commitment was, let's help the authorities at the local level, municipal health and housing authority, to set targets and priorities. And this was why we moved to the second step, that was a decision step, where 15 high-level officers and policymakers were convened to share their knowledge on which was the potential benefit in reducing inequalities in attributable mortality to education, to family support, to income, to poor housing, to social context, to occupational quality, and to built environment. And they provided to share this evidence and this knowledge they have. And they went through Delphi. Sorry. We lost the presentation. Can you see the presentation? Okay. And they decided, they arrived to a consensus, they reached a consensus on the ranking of these 23 policies. Can you see it?
No, we lost the presentation.
Lost the presentation. Where is it? Let's come back and to share again.
Yeah, wait, probably it's coming.
Sorry.
Okay.
Well, they reached this conclusion in this second step.
Just full screen. Okay.
This was the ranking of the 23 policies, and you can see, in fact, at the top of the benefit in reducing health inequalities were all the policies of the social, acting on the social context, as was mentioning Mauricio, and at the bottom were the one acting on environment, on physical environment. Probably, so this is the shared knowledge among the stakeholders and decision makers of the expected benefit of this exercise. And the conclusion was that what was important was to try to exploit the potential for interaction between actions and interventions that are more promising in this ranking in reducing health inequalities, and to focus on the more deprived areas. And the decision suggested to the authorities, the city authorities, was to search for the best window of opportunity that were to test and pilot this kind of recommendation on priority. And in fact, the window of opportunity was the new strategy for chronic disease. And this is the example of diabetes, where we implemented this new strategy at the local level. We again used the storytelling of the metro line, showing that the prevalence of diabetes was just increasing when moving to the poorer neighborhood, and additional qualitative and photo voice survey showed that which were the opinion of the diabetic patients in this area about the relevance of different determinants. And what we decided it was to build two different community of practice. One was made of health professional, and the other was made of stakeholders, local stakeholders that were committed to go through these inequalities in diabetes prevalence and to look at the mechanism generating these inequalities and try to identify which is the responsibility for avoiding this mechanism. The main decision was that some of these solutions were in hand of the same local stakeholders. They can be implemented immediately, while others were under the responsibility of city institutions and actors when feasible. And again, others were not under the responsibility of anybody, neither at local and city level, that the private enterprises were maybe interested in participating to call to make innovative actions if adequately funded. And this was the new community of practice of more than 100 enterprises of this Torino social impact that were involved in this process. So this was the Turin case study, but immediately this Turin case study, starting from diabetes, was suddenly hit by the COVID pandemic, and diabetes, like many other chronic diseases, are the more causes determinants of susceptibility to COVID. In fact, this inequality in COVID in diabetes, these are the relative risks of diabetes for high to low education, are the same for mental disorders and are the same for inequalities in mortality due to COVID. So what we decided is that this experience was ready for being applied and replicated in the COVID case. In the same community, we started an exercise of scrutinizing an equal mechanism of health and care in the case of COVID, an equal mechanism out of the health sector, that are the one that makes important to have an health equity audit at the local level of the potential causes of inequalities in the COVID for elderly people. And in fact, many of these mechanisms are particularly important for elderly people in our specific deprived neighborhood. And this is the launch for the Trieste case study, because the Trieste case study just suggested how to do it, how to manage this kind of special need of reducing health inequalities at the local level. Because the Trieste case study was asking us to make a retrospective evaluation of what was the impact of this local intervention that was an integrated social health and housing program targeting 15 micro areas in the Trieste city. And it was aiming to create social cohesion and promote and protect health through integration between sectors and to activation of people. And this intervention that was in place since 2005, due to the crisis, austerity post-crisis, was just asked to demonstrate its sustainability, because it cost a lot. It cost more than 200,000 euros per year per micro area. And so a participative assessment of what works and why does it work was initiated for this purpose. And the intervention was mostly a mix of outreach, community development, and health intervention made by these three integrated intervention from health, social, and housing authorities. And we initiated a qualitative study with the 40 professionals working in the local team. And with them, we identified the social mechanisms that were activated by the intervention, and which were the properties that this social mechanism has been able to activate in terms of new social capital, but not a generic definition of social capital, but the kind of social capital, property of social capital, that were able to enforce those capabilities of the people that are able to face critical problems. The professionals identify 24 critical problems or usually encountered by people resident in this area. And in fact, they were able to identify a lot of these mechanisms, and they decided to go with a quantitative analysis of how and why the intervention was able to improve the capacity to face these 24 problems. They worked with a case control study, well, it was not a retrospective court study indeed that you can interpret it in many ways, analyzing 200 treated in micro areas, 200 untreated in the same environment, and 200 untreated out of the micro area, matched by propensity score matching at the beginning of the intervention. And what was interesting is that the results demonstrated that in fact, the intervention was able to address the people suffering more from these 24 category of problems, and the treated benefited more from the mechanism of generation of social capital in solving this problem. And at the same time, mental health among treated was better than expected. They never been treated. And the final conclusion was that this intervention was able to produce as an impact more social capital, not generic social capital, but social capital as a resource generator, providing more active and passive relationship and more sensitivity, creating trust as a positive expectation of cooperation in the environment, and making public services capable of activating people and capacitating people, and of providing better quality and integration of the intervention. So this is exactly what Mauricio was saying, that the solution is to increase the quality of the social environment and social support and social cohesion in the community, because this is really able to improve the mental health of these deprived communities, where most of the interventions that were ranked in Torino as able to improve social determinants in health. The conclusion, of course, we have more from other cities that we can go through all these results. But let's conclude about, yes, it can be done to link evidence with stakeholder engagement in going through improvement in policy response at the local level, but under specific conditions. If you go back to the policy cycle at the social level, at the local level, starting from this engagement of stakeholders, building with them the health profile, finding solutions, setting targets, implementing changes, and monitoring progress. What we have found is this both prospective in the case of Turin and retrospective in the case of Trieste, where and when evidence really does matter. In fact, in the case of Torino, evidence matters if you are able to use appropriately the equity lens, transforming your metric, common metric between policy sectors, using the health metric and the health inequality metric to make different sectors to speak each other. And this metric mechanism and the storytelling of health inequalities are very useful to understand better which are the health gains that can be provided by each of the intervention, and to choose priorities and to move to input for the impact finance to enroll also the private sector to be. While the other conclusion from Trieste is that the social capital is the key point in this. In social, we have seen that we started from the motivation of austerity and looking at does it work, why does it work, the professionals were engaged, they identified the expected income, they identified the mechanism that were activated by them and the health outcomes, and most of the message was about the importance of the social capital, specific social capital able to solve problems. And in any case, sorry, in both cases, both the Turin case and the Trieste case, action research was the important mechanism, model of engagement of stakeholder and decision maker in order to make them to use to make the best use of evidence. And so the final conclusion is that no data, no problem, action research is important, and health equity metric is the common language to be used for doing this. But it is not enough if you don't consider the fact that you have to be opportunistic, as was mentioned also by Frank. Is not easy. Whenever you try to consult stakeholders and decision makers, usually it depends on the moment, on the specific time you consult them, and if there are any window of opportunities for them for considering the evidence in effect as an important input to the activity. And in fact, sustainability in Trieste, the Turin social impact agenda in Torino, the new chronic care model strategy in Torino, the Turin review in Torino were the best window of opportunity that were explicitly weighted and used for right to this conclusion. So my main conclusion is that we had in MINDMAP the possibility of knowing different experiences of integrated community care and prevention. And of course, in the region for health or LTCT network, there are you know a lot of experience in the field of community intervention, and they show very different phenomenology of experiences. Some are centered on person, on policies, on professionals. They focus some on care, some on community, some on environment. The core ingredients of the intervention may be home intervention, place intervention, asset intervention, policy intervention. But what is common for the success of this experience is when they are able to have an intended, intentional impact that is centered on co-production. Agents are agents of change, where you provide local alliances, they are oriented to value of individual and community. They are explicitly focusing and strengthening quality through investing in social infrastructure and enabling co-creation, and they include evaluation and adaptation in their action research process to integrate knowledge with decision. And 6 common qualities of these intentional strategic actions of integrated community and preventive care, not a tool, but a societal process, are sorry, that they are integrated actions centered on the quality of need of the person. They try to ask for an active and pair role of the person, generating horizontal relationship. This is the kind of social capital that is created to solve problems, and using an active role of the place and environment. In Trieste, it was quite clear. Celebrating and exploiting the collective reads that are integrated in daily life, that can shape identity and provide the trust between professional people, and in alliance and partnership. And look, these 3 groups of conclusion are Some are about evidence, some are about social capital, and some are about windows of opportunities. The typology of experience are different because windows of experience are different. The role of evidence in this kind of set of properties and the role of social capital in this one are the more important conclusion from our experience, in close relationship with the conclusion from the content part of scientific evidence provided by Frank and by Mauricio. Thank you.
So thank you very much, Professor Costa. Thank you, Professor Van Lenthe, and thank you, Professor Avendano. I think that you gave you provided many input, and as we are in the context of the Healthy Cities Network and regions for health network, I suggest the participants to focus on implication that this kind of project like MINDMAP can have at the city level. I think that it was very interesting to listen to you how you move from data collection, from big data collection to storytelling, to research action on action research. And I think that this should be very interesting for people working at the city and the region level. So what I ask participants is to raise, it's possible to raise a hand. There is Christopher, I give you Chris, okay. Okay.
Yes.
So,
just while people are thinking about questions, I have a number. I'll just do an initial one for Frank. In the early slides, Frank, you showed a slide that showed depression amongst older people and compared, I think it was Norway, with the Czech Republic and Russia city. To what extent is that the result of a national policy, and to what extent is that city policy? So really the question, I suppose, is how do we get a kind of a nice benchmark that shows what is doing well within Norway, what's doing well within Russia at a city level in terms of mental health? And is there anything you can say about trends in mental health at a city level from the studies that you've done? Thank you.
Frank, you don't have the audio. Okay.
Sorry. Yes, I think that's a good question. No, the slide that I used was to illustrate that we have this variation in depression in these different studies. You're right that this is important to see to what extent this is specific for a city or specific for the country. That's not in this slide, but it's, I think, fair to say that the high levels of depression that we saw in the Czech Republic are to some extent, of course, due to the hard financial circumstances that people suffer there, which are completely different from the situation in Norway. So before we actually conclude that an urban policy should actually try to get and to eliminate some of that variation, it would be good, of course, to see to what extent this is representative for a country or for a city. We should be able to explore within the studies that we have whether depression over time increased and whether that in some studies increased more than in others. But then again, of course, there are also trends in cities and trends in countries that may affect this specific situation. So that's sometimes difficult to disentangle, and was certainly not in the slide that I presented here.
Okay, other question? I think that yeah, I hope to be able to not to miss anybody. Okay, I think that the people need a little time to think. So maybe that I have a question for the three of you. I think that it was very interesting what Giuseppe said about the policy windows. So in Torino, there was a policy windows with the chronic regional plan. And I wonder if it is possible and how it is possible for researchers to force to open policy windows when there are not. So in which way, what kind of, from your experience, how if you can underline a little bit more how it is possible to open this policy window?
Yeah. Shall I start?
Yeah.
Well, I don't think actually that we need to enforce this. The cities that I'm aware of in the Netherlands, for example, are really open for policies. They're very open for coalitions between scientists and policymakers. So, for example, the city of Utrecht, where I work 1 day a week, is already striving for this for many years. And that's actually done very well. There is increasing interest in showing that physical and urban determinants are really underlying structural drivers of public health. I see that the links between research, university research perhaps, and local level staff is getting increasingly easy, also because of funding agencies increasingly require that projects like MINDMAP are a combination of science and policy.
Thank you. Would you like to add the?
Yeah, maybe if I can just shout out to that. Yes, I think that's a really good point. I think one of the lessons from these projects is that working very early during the research in involving policymakers is really important, but also in trying to understand who the users are of the research that's been done. And that enables sort of to open windows. We have in the UK, we have something which is called the Center for Society and Mental Health. And for example, here we have coming to our research project meetings, we have, for example, NGOs, but also people with mental health problems, members of the local government joining our meetings and helping us to have decisions. And this is in some way what we try to do with the leadership of Giuseppe in this project as well. So I think involving sort of the users then over a long period of time, building a relationship, it's what enables these sort of windows to be open eventually.
Okay, Giuseppe, you wanted to add something?
No, I have to add more. I think that it depends, of course, on the culture of different countries and areas. In Italy, the culture of policy analysis is very poor. So it's the integration between evidence and policy making is at the very beginning, and many times is also instrumental and opportunistic. So we have to build structures and mechanisms of governance that are able to systematically include evidence in the process of need analysis, target setting, priority setting, and evaluation of impact. However, so in this case, in our cases, windows of opportunities are quite important because they may be accelerators of processes of inclusion of evidence into practice. But we have also to consider the fact that the COVID pandemic has changed a lot the confidence of people and of stakeholders and decision makers on science compared to the past. And, and this is another general window of opportunity that should be exploited for improving our ability to value the kind of evidence we have produced and we can produce in the future. So if I think that we can take this opportunity to improve our capacity of integrating evidence and science into policymaking.
So I still have another question that is strictly connected to the COVID. Actually, in a way, you have already anticipated, but I would like that the three of you focus a little bit on COVID outbreak and saying if this could be an opportunity or not for what Giuseppe was saying just right now, could be an opportunity for setting a new platform, a new way to work together with the stakeholders and policymakers, in your opinion? And if yes, this could be possible not only in advanced country like the Netherlands. I agree with Frank that the Netherlands, the participation of the user, of the clients to policy making is very high. But we are in a webinar, in a seminar at WHO European level. And so we all know that the situation is very different in different cities around Europe. So do you think that it is possible to export this kind of experience in other cities with a lower level of participation? And how much this can be influenced by this new experience for everybody of the COVID?
Well, I think that is a complicated question. I think that there are really good reasons to focus on our physical and social environments when it comes to the COVID crisis. So mental well-being is one of the top outcomes as a result of the crisis, of the lockdown, of everything that happened over the past month in Europe, in European cities. At the same time, we have seen that the streets were empty and open for pedestrians and cyclists. We have seen how life changed over the past month, and that of course is reason to think that we should move along those lines in the future, not get back into the situation that we were in, but actually trying to build on that kind of experiences and try to come up with new solutions, how to make areas walkable, green, sustainable, etc. At the same time, I think that this counts for quite a few policy areas. It counts for urban health, but it also counts for education. It also counts for social policies, etc. So there will be a kind of a competition, but it doesn't mean that we shouldn't be aware that this urban environment is so important, and that has been clear over the past months that it is very important. Whether that helps other countries to come up with a similar situation, yeah, it's very difficult for me to actually say so. This needs a kind of a long-term investment in setting up a system where it is actually includes some incentives to collaborate between science and scientists and policymakers in projects. I think many of us agree that it's very beneficial to do so, but it's and the situation that we're in now really helps. But I guess it will also help in many other fields of research, and that may, in realizing the system, may perhaps make it complex to realize.
Yeah, I agree with Frank. Just to add, I wanted to mention, just emphasize upon the point that Frank mentioned, which is the the fact that I do think that the COVID-19 situation does open a window of opportunity where we can bring some of these issues, but many of the challenges that our sort of cities are facing in response to COVID-19 involve also a national component, not only local policy, but also national policies. And we encounter this kind of, let's say, conflict, but also opportunities for people who work in improving life of all the people in the cities. It's really potentially too narrow to think of only of sort of regional or sort of policies within the city. We had this in our project, for example, some of the policies that we looked at, such as the bus pass program or home care policies. We looked at how these policies influence people living in urban environments, but actually these policies are defined at the national level. So you know, if we focus, you know, I think this focus on policies at the national level is really critical. And I think COVID-19, because it has such an impact on both sort of urban and not sort of rural areas, it offers an opportunity to put a lens over those policies that at the national level, for example, home care policies that, you know, in the case, for example, of the UK, turn out to be very important on how to provide care for people at home who cannot be helped by their informal carers, by their adult children or family members. So I think this COVID-19 is a kind of a unique case that opened a window of opportunity for those national policies, perhaps also to some extent for more local ones. And I'd be interested to hear experiences of somebody sort of in the room of policies that might be interested to evaluate for us in the research as well. Thank you.
Giuseppe?
Yes, in fact, when I mentioned that the pandemic was a window of opportunity for us, for our case study, was also related to the fact that this experience is being asked to be replicated in other cities and regions. Because when we proposed this checklist of mechanisms through which the pandemic was able to increase health inequalities, this checklist was asked to be replicated, populated with indicators and with specific actions that are able to solve this mechanism from other cities, the Italian and so on. And in fact, we are using this checklist, whose main message is that the inequality lens is health inequality lens is the best metric to make policymakers and stakeholders to interact with the final measure of income. And the pandemic is a good window of opportunity, both for the new confidence provided to evidence, but also to the new sensitization, to the new confidence that people and stakeholders have around inequalities. There is a shared consensus on the fact that inequalities should be tackled in this occasion. And this kind of main message from our part of the MINDMAP project is really sustainable and replicable at the city level. Find this tool for those that are willing to replicate it.
Okay, thank you so much. I think that we can move a little bit on, but there is one question on the chat made by Chris. So I think that Chris, if I give you the voice, you can ask directly. Okay.
Sure. Sorry, I'm just. So thinking about long-term. Beg your pardon. Can you think about long-term care in the home? You said that seemed to have an impact on mental health well-being in older people. Did you find any variation in how that long-term care was given and the impact? So, for example, does it matter how long the person goes in for to give the long-term care? Does it matter if it's the same person every time? Does it matter if, in terms of their professional role? That's the question about long-term care. I also note, of course, that what you're actually saying is we need to take a system-wide approach. And I very much welcome your idea of engaging with policymakers at the beginning of the process to think about what should be in that part of the system. So that's one, on long-term care. Does the form of long-term care in the home make a difference? And two, just a statement that I recognise that actually a system approach is what is needed and should be developed at the start of a piece of work, and I very much support that. Thank you.
Thank you very much, Chris. Perhaps I can start with a question on long-term care. So studying the impact of long-term care on actual outcomes is very challenging because people only get to become eligible to use formal long-term care when they are having declining sort of physical, mental, or cognitive health. So it's always very difficult to understand what the impact is. Now, what we did in this project was more to focus on a kind of insurance system, if you like to call it that way, that the different countries have in terms of who is eligible and when somebody becomes eligible to any care provided by the formal system, which in some cases is subsidized by the government, provided by the private sector, or in some cases is directly provided by the government. So the conclusion is not so much regarding different types of care at the home, but it's more about the generosity of this system. And basically what we find is that basically the lower the threshold for someone to become eligible in response to declining health to long-term care, the better the outcomes of mental health are. And this included, many sort of types of health, of long-term care, including sort of help with very kind of specific activities of daily living, to help with shopping, cooking, and understanding literature and so on. So there are many different components, and it's very difficult to disentangle which ones or which type. I think this is something that was very relevant during the COVID-19 period. In some of the countries that we looked at, for example, the majority of the people who we concluded were in need of some kind of formal care were not eligible, according to the regulation of where they were living, were not eligible to receiving long-term care. Now, in the absence of informal carers, because of the limitations that the confinement might pose, this brings these individuals on extremely higher risk. So I think this illustrates in this, for example, crisis that we're having now, how changing the eligibility rules can have a major impact. But yeah, so our focus was mainly on this kind of overall aspects of the design of the long-term care system provided at home. And perhaps, Frank, if you wanted to respond to the second question.
Yes, sure. It was about the systems approach. Yes, I think this is really a way to go forward, because I have seen, and I've worked over this for a long time now, that we still apply too much. What I call something like single risk factor epidemiology, where there's an enormous amount of studies looking at green, for example, and health. And we all tend to agree that it's not just the amount, but also the quality of the green, but also the social function of green. There are areas in cities which are extremely green, but still very deprived, and as a result, also very often very unsafe. In the Netherlands, this is, for example, famous in the area of Amsterdam, where in the 60s and 70s we built a huge new part of the city with lots of green, but then funding was gone, and it mainly attracted poor people, and it became quite unsafe. And all those elements, the intended elements, but also the unintended elements, are important to have clear at the beginning, particularly also because it allows us to evaluate what will happen over time. And there are increasingly approaches where we can use like a participatory approach with both the residents and stakeholders to understand really in the beginning how the system works. And that system is not just about green in the example, for example, or about any other factor, but it's about a combination of factors with intended and unintended consequences. And the ability to start from that participatory approach leading, for example, to more complex models where you could actually calculate the impact of a number of factors, is, in my view, an interesting exercise, because from the start on we bring all the knowledge in, and we're ultimately able to investigate the consequences of this. And that's also relevant because many of these consequences are not elements that change overnight. Real changes in the urban environment take time, and in some of the agent-based models that we have done, that we explored in the past, we actually found out that it takes, for example, 10, 15 years before you see a change. So yes, here I think again is an opportunity to work with these kind of models. If we relate this to COVID, we all depend our public health at the moment on complex models. And I think that in our research field, this in the next years will also become increasingly important to do. And it's a great way of working together with residents, but also with stakeholders to build up new evidence on some of our policies.
Okay. I think that we should move to the final comments from our invited speaker, Pirous Fateh-Moghadam. I would start from you, and then Giuseppe Costa. But before giving you the floor, I would like to remind you that there are some things in the chat that are really interesting to read, and especially I would like to quote Stefania. She wrote that she really appreciates your will to share. Sorry, I lost the point. Your will to share the result. I think this project allows for a great step forward in health promotion, since it provides evidence on and integrates many aspects influencing mental health. So I really, I think that we have to thank Stefania from this comment. Pirous and Giuseppe.
Yeah, thank you. I want to add my thanks as well to all the presenters and speakers. It was really very interesting to listen to all the presentations and to the discussion. I am speaking on behalf of the Regions for Health Network, and which is a network of regions in the European a European network by WHO. And why does this network exist, and why is it important for the WHO? Because many of the national policies originate at regional level, and at any rate are implemented, and the national policies are carried out and implemented on a regional level. And so for WHO, it's important to have a network not only of nations and states, but of regions as well. Now, what is true for nations in relation to the regions, I think is very much true for regions in relation to the cities, because where do the people live? In cities, most of people. So the collaboration with healthy city networks or other entities like universities that are involved in issues concerning city shaping and for a better health is of crucial importance for the Regions for Health network. And what can we do? It was very interesting, for example, the remark of Frank Van Lenthe that the issue of the green spaces, it's not simply add green could not be enough. It has to be part of a more comprehensive strategy that puts the person and her needs at the center of the policy development, and that permits participation, which is needed. So, of course, there's all the connection with sustainable development goals on this issue of urban health, of a multi-sectoral approach, and as Frank says urban regeneration as a package, a systems approach. Like I liked very much the slide on the public transport and depression symptoms. So I think tomorrow I will get a seasonal ticket. So I saw there's good news. I'm 53 years old. I saw after 50 it goes down anyway. We're getting better anyway till 70. So, and if you participate at public transport, you will feel even better. But here is the other issue of COVID, for example. This is another issue. Public transport now is many people are preferring to go if they are able to by car and private transport instead of public transport. So this is something that adds into the predicaments of induced by the COVID experience, that highlights, as the presenter said, the importance of a healthy urban environment. We all made this experience during lockdown. It depends on if your immediate surroundings are nice. It's very important if you cannot move so much away. And elderly people are very limited to a more nearer environment on their homes. What is, in my opinion, very powerful and in all this approach is there is an intrinsic sustainability, a long-term sustainability of those policies. Because if you think of architectural and urban infrastructure interventions, it's the way you construct a building is of paramount importance, because the building will last for years and for 100 years. Many of our policies and what we are doing at public health promotion, there are projects, and if they are lasting some years, it's a very good result. But those policies are lasting. The building my apartment is in is 100 years old, and it has thick walls, and this is nice because I'm cool here. It's compared to other friends of mine have new houses, and they have to have air condition. I don't. So I'm very grateful for people for more than 100 years that planned the building. That was part of a social housing policy at the time, and so. This is what I mean with sustainability, long-term sustainability of those interventions. And now this again, and I conclude with this thought, makes it so important, the collaboration between different entities like the RHN, the Healthy Cities, all universities working on this issue, also to be more effective, to push the agenda on the decision makers on this specific and topic of paramount importance. So thank you very much for your work. If we will have the slides, we will forward them as well in among our contacts, and looking forward to further and future collaborations. Thank you.
Thank you very much. Pirous, for your conclusion remarks, and I think that the last words are from Giuseppe, and I just have a practical information. I think that we have to collect the two presentations in PDF so that they can be shared. So next week we will send you, and you can share with the network. But also we got some email, and so we can also send to those email of the participants. So Giuseppe.
We are quite out of time. I don't think that I should add anything more. Thank you to both networks, WHO Europe, for hosting this presentation. I think that our main interest is to try to disseminate as much as possible the main messages that may be relevant for stakeholders and policymakers. Bye-bye to everybody.
So thank you. I also joined my thanks to, and also on behalf of MINDMAP partners, I would like to thank especially Chris and Pirous for helping us in the organization of the webinar. So thank you very much. Have a nice evening and a nice weekend. Bye-bye.
Thank you very much.
You too.
Thank you.
All right. Thank you.
Bye.
Goodbye.
Goodbye, everybody.